Hello everyone. Today we are going to review a chronic cough for your NAC OSCE exam. My name is Dr. Kishandi Thompson. Please note that this video is for educational purposes only. It is not a substitute for professional medical advice. Please consult your doctor before making a decision about your care. Chronic cough is defined as a daily cough for greater than 8 weeks. In children, it is defined as a daily cough for greater than 4 weeks. You will be given some important information on the door. Please note the patient's name, age, gender, and the complaint. Also note the duration of the complaint, as this will help guide you on your approach to your exam. The examining committee will ask you exactly what they want you to do in this exam. Here, you've been asked to perform a physical exam and take a history. Also note the patient's vitals. Important things to note in chronic cough include temperature, respiratory rate, and oxygen saturation. In the exam, it is best to have a minimum of 5 differentials in mind, as you will begin to rule out as you continue to question and get more information from your standardized patient. Some common differentials for chronic cough include asthma, gastroesophageal reflux disease, upper airway cough syndrome or postnasal drip, congestive heart failure, pneumonia, malignancy, tuberculosis, chronic bronchitis, medication-induced cough, environmental causes. Upon entering the room, greet the examiner, provide your identifying information, then greet the patient and introduce yourself and your position. Confirm the patient's name and age, and ask how they would like to be addressed. Here you'll begin to build rapport with the patient. Assure confidentiality at the very beginning so the patient will be free and feel confident in answering any question that you may ask them. Ask the patient to tell you in their own words their concerns. Inquire of their overall general health, and give a brief outline of the next steps. Then take your history. Use whichever mnemonic that you feel most comfortable with, but ensure to ask the onset, was it sudden or gradual? The course, has it been constant or intermittent? The duration of symptoms, is the cough getting worse, improving, or remaining the same? Are there any prior episodes similar to this cough? The setting in which it occurs. Does it occur when they're laying down flat, or with exertion, or particularly at night? Ensure to ask of aggravating factors. Does the cough get worse with exercise, smoke, or changes in weather? Are there any alleviating factors, like inhaler use, resting, sitting upright, or antacids? Are there any associated symptoms, like chest pain, dyspnea, wheezing, etc.? Here you can ask about sick contacts. If you forget to ask here, you will have another chance to ask in your social history. Has there been any sputum production? Then you will ask about coca-B. Color, odor, consistency, is it thick or thin? The amount, is it a teaspoonful, tablespoonful, and is there any blood? You want to make a complete review of systems, and you want to target your top differentials that you've made up to this point. For example, if your top differential includes asthma, you want to ensure to ask questions about wheezing, dyspnea, or exercise intolerance. If your top differential includes gastroesophageal reflux, you want to ask questions related to heartburn or a metallic taste in the back of their throat, or symptoms when they're laying supine. If your differential includes postnasal drip, you want to ask questions like runny nose, nasal congestion, or constant need of clearing the throat. Ensure to ask for the red flags, because these are things you don't want to miss, such as fever, night sweats, weight loss, weight gain with peripheral edema that can indicate CHF, hemoptysis, severe dyspnea, dysphagia, or hoarseness that could indicate malignancy, or current tobacco use. Continuing your history, the past medical history. Have they ever been diagnosed with any respiratory or cardiac illness? If relevant, you would ask the past surgical history. Was there any family history of atopy? What medications are they currently on? ACE inhibitors or beta blockers are ones that you especially need to listen for. Do they have any allergies, food or medication? If any medication allergy, you want to ask the type of reaction. Is there anaphylaxis, hives, etc.? Are there any environmental allergies? In their social history, you want to ask questions about their work. Are there any changes in the work environment? If they're in construction, you want to think about asbestos exposure. And you also want to keep in mind any other occupation that can lead to any form of interstitial lung disease. You want to ask about their home situation. Is anybody sick at home? Was anybody recently diagnosed with tuberculosis that they've been in close contact with? Was there any recent travel to a TB endemic area? Are there any pets at home? Do they smoke? The question you want to ask, have you ever smoked? This will lead them into answering yes or no, and you would want to ask how many cigarettes a day they were smoking, how many years they're smoking for to estimate the pack year history. In a typical week, how many alcoholic beverages do they consume? Any recreational or illicit drug use? What's their sexual history? You want to know the number of partners that they've had. Do they sleep with men, women, or both? Have they ever been diagnosed with a sexually transmitted disease? This is especially when you're considering patients who have HIV for PJP pneumonia. Are the immunizations up to date? What immunizations have they had? What's especially important to note in those who smoke, because these are red flags for malignancy. Any current smoker greater than age 45 with new or worsening cough or voice changes, or patients that are 55 to 80 years of age with greater than or equal to 30 pack years who are currently smokers or quit less than 15 years ago. Moving on to your physical exam. You want to obtain consent before proceeding. Ensure that your hands are clean before touching the patient. Refer back to the vital signs you saw at the door. Let the examiner know if the patient was febrile, tachypneic, tachycardic, or had low oxygen saturation. Ensure adequate exposure and proper draping. You're going to do two examinations here, the respiratory and cardiovascular examinations. Begin by looking at the head and neck, looking for signs of central cyanosis. You can ask the patient to open their mouth and look at the tip of the tongue and lips for signs of central cyanosis. Lymph node examination, starting with the occipital, postauricular, preauricular, submandibular, submental, anterior and posterior groups of cervical lymph nodes, and supraclavicular and infraclavicular lymph nodes. Look at the hands for peripheral cyanosis, clubbing, or nicotine staining in smokers. Inspect. Look at the body positioning, the shape of the chest. Is there any kyphoscoliosis, pectus excavatum, or carinatum? Any masses, skin changes, scars, use of accessory muscle use, pursing of the lips or nasal flaring? Is there any signs of cachexia or audible breath sounds? And look at the symmetry of respiration. Palpate for tracheal positioning, subcutaneous emphysema, tenderness, tactile firmness, and chest expansion. For chest expansion, that is going to be done by using a tape measure at the level of the nipples. Percussive lung sounds, such as dullness, which is an indication for consolidation, mass, or effusion. Resonance, hyperresonance, or tympany. Auscultate for equal air entry. Are there any wheezes, crackles, etc.? Moving on to the cardiovascular exam. You want to look at the legs for any signs of peripheral edema. Palpate for pulses. Ensure that they're equal. Locate the point of maximal impulse. Auscultate for heart sounds. Note if there are any rubs or murmurs. If you don't have enough time, ensure to mention that you will examine for the JVP. Investigations you want to order with those with chronic cough. You want to do a CBC with differential and ABG electrolytes. an acid-fast test, ESR and CRP. Cultures, you want to examine both sputum and blood cultures. Sputum cultures, you want to look for cytology, gram stain, and cultures. You want to assess for an INR and PTT for those who are hypercoagulable, a nasopharyngeal aspirate, a BMP, and viral testing. You want to do PCR for influenza, COVID-19, and RSV. Imaging studies include chest X-ray and chest CT. Other tests include pulmonary function tests, which include spirometry, the bronchial challenge test, the bronchial reversibility test, methacholine challenge, the single breath diffusing capacity test, which allows you to differentiate between intrapulmonary or interstitial lung disease and extrapulmonary pleural effusion causes. Allergy testing, bronchoscopy with or without bronchoalveolar lavage. If there's a cardiospecific cause, you want to investigate with electrocardiogram and echo. Perform an endoscopy, 24-hour esophageal pH monitoring or barium study. On to management. I like to divide it into short and long-term management. Always do your ABCs. Depending on the setting, you want to set up an IV line attached to the cardiac monitor and provide supplemental O2 for those who are hypoxemic. Direct your management towards your top differentials. For asthma or COPD, SABA, LAMAs, or inhaled corticosteroids. For GERD, lifestyle modifications, PPIs, or H2 blockers. For upper airway cause syndrome, first-generation antihistamines are recommended, along with decongestants such as oxymetazoline and pseudoephedrine. Provide intranasal steroids or saline rinses. For CHF, medications include ACE inhibitors, beta blockers, digoxin, diuretics, antiarrhythmics, anticoagulants for those who have concomitant atrial fibrillation, and spironolactone. For medication-induced cough, you want to switch your patient from an ACE inhibitor to an angiotensin receptor blocker. Where necessary, isolate, provide IV fluids, and give antibiotics. You want to always refer to a specialist, whether it be a respirologist, oncologist, and always refer back to their family physician if presenting inside the emergency room. For long-term care, you want to remember those infectious causes that need to be reported. You want to encourage smoking cessation in those who are smokers, and those who have irritants to smoke, they want to avoid the exposure and ensure that the vaccinations are up to date. At the end of your encounter, the examiner will likely give you 3 post-encounter questions. Some common ones include, what is the most likely diagnosis? How would you manage this patient? What investigations would you order? You may also be given a chest X-ray to interpret. Some common ones to look out for are those of COPD, which can include flattening of the diaphragm, hyperinflation, and a long and narrow cardiac silhouette. For CHF, you can remember the mnemonic A, B, C, D, E for alveolar edema or bat winging, curly B lines for interstitial edema, cardiomegaly, dilated prominent upper lobe vessels, or pleural effusion. Some tips to remember are to have an organized approach to your encounter. You want to build rapport throughout. This can be from remembering to address them correctly, remembering what their name is, giving them a sip of water if they're coughing, or providing a sanitary napkin. You want to show empathy when indicated. Always, always avoid using medical jargon. This lowers your score in communication. You want to always speak slowly and clearly to get your message across. Remember to pause if you need it, because this allows you to think and process the information that you've heard in order for you to answer or ask a question correctly. Good luck everyone in your upcoming exam. I wish you all the best. Thank you.